Molweni. Hello, everyone. Welcome to the first ever Bulungula and Cape Town Resilient Community Webinar. My name is Lihle Mbigwana, a vibrant village manager at Bulungula. We will start by asking Rijan Modrov to give us a quick background of Bulungula Incubator. She is the director of the incubator and the founder of the incubator. Over to you, Rijan.
Okay, thanks, Lihle, and welcome everybody. Thank you so much for joining. I won't speak for very long. It's really to welcome you all and to kick off our very first webinar series. We're really excited to be kicking off this series. The topic, as you know, today is focused on a health program. And we're going to be aiming to do this webinar series on a monthly basis. So we will do that from next year. This will be the last one for this year. We'll look at a range of topics. There'll be from sharing and learning around community stakeholder topics, M&E systems, data management, in youth development, job creation, job skills programs, education, of course, ECD, all the way through to high school, e-learning. So we will look at the wide range of topics and everything that could be interesting in holistic place-based development, and anything that could be interesting in developing, sustaining and facilitating the growth of resilient communities. So we're very excited today to introduce our partners from the Chronic Disease Initiative for Africa. And like I said, the focus will be on health. The Bulungula Incubator, essentially our work in the area here on the beautiful Wild Coast started as far back as 2004. We come up on a 20-year anniversary in terms of development initiatives in the area, because it essentially started with the Bulungula Lodge in 2004. And health was really one of the first things that we looked at, because in 2006, a third of the babies had died of diarrhea in this village. And 1 in 9 families have lost 3 or more children. We know families that have lost 8 children to diarrhea. Since the Bulungula Incubator Health Program has developed, which is now managed in partnership with the Department of Health, infant deaths from preventable diseases is completely unheard of. So we want to be talking about that journey, bringing in the journey of everybody else doing good work in the sector. Today, we have people on the call with us from the Department of Health, from other NGOs, from research institutions. Some of our funders are joining us today. Thank you so much for your support. So we hope that we'll have lots of opportunity for sharing, and please get in touch with us also with interesting topics that you might have, and we can continue to do the good work that needs to be done to ensure the growth, development and the thriving of all the communities that we live in. And I'll hand back to Lihle to carry on with the program.
Thank you so much, Rijan. Just a few quick housekeeping notes. Please note that we are recording today's webinar, and then it will be live on our YouTube channel. I would like to introduce to you shortly a presentation that we will get from Myrna Van Pinxteren. Myrna Van Pinxteren, as an emerging global health researcher, Myrna Van Pinxteren has an impact in chronic illness of health on my apologies for the first time. I feel nervous. It's an honor to introduce to you Myrna Van Pinxteren as an emerging global health researcher. Dr. Myrna Van Pinxteren explores the impact of chronic illness on health and well-being of people, using community engagement. She is committed to co-create text-specific solutions that tailored to the unique needs and challenges of people living in marginalized communities. Currently, Dr. Van Pinxteren is a postdoctoral researcher affiliated with the Chronic Diseases Initiatives for Africa, CDIA, and at the University of Cape Town. Her work both quantitatively and qualitatively explore the impact of treatment burden to enhance the self-management support system and healthcare services deliveries for chronic ill patients in low-income context in Africa. Previously, she worked as a researcher coordinator in a school of public health at University of Cape Town on 7 years NNI project, ILAM, using information to link aligned services retain men in HIV cascade. Primary focus within this project was to optimize the utilization of health information in Cape Town whilst comprehensive care and rotation of men in HIV continue. I now invite Dr. Myrna Van Pinxteren.
Great. Thank you so much. That was a very beautiful introduction. Thank you so much. That was lovely. I'm just wondering if I should share the presentation from my side, or do you want me to, are you guys having it loaded on your side? Because I'm happy to do either or.
I think you can share, Myrna. Thanks.
The problem is oh, I can. There we go. Perfect. That should be it. I'm just gonna swap. There we go. Can everybody see my screen?
Yes, that's perfect. Can go ahead.
Perfect. Great. Thank you so much. And thank you so much for the fantastic introduction, but also just for the invitation to be here and setting up all the admin. It's been lovely. And today I am presenting some findings from the extra study, but I'm not doing that. I'm doing it alone, but on behalf of my colleague Charlotte Sloan and Professor Naomi Levitt. And yeah, so I work in the Chronic Disease Initiative for Africa. We are a center at the University of Cape Town in the Department of Medicine. And today I will be presenting the results of the extra study, which is a very small qualitative study that stands for exploring the treatment burden and capacity for self-care among patients with HIV and NCD multimorbidity in South Africa. So this has been a while ago. The actual study was done a while ago, the data collection. So we've actually done 30 interviews with people living with multimorbidity in Cape Town, Bulungula Cape Town, as well as the Bulungula Eastern Cape, between February and April 2021, which was in the middle of the pandemic, which really has changed the findings that we were able to collect. And we collected our data in public health clinics in Bulungula and by visiting homesteads in Bulungula. And hereby we worked very closely with the Bulungula incubator and are especially grateful with the help we've received from the Nomakayas during that time. So what we did, we also used the treatment burden theory as the theory behind our study, whereby we specifically researched how living with 2 or more chronic conditions are impacting the workload, which is the work that people have to do to stay healthy and access the health services. So what we found in our study, it was a comparative study between a very rural setting in the Eastern Cape, Bulungula, and a very urban setting in Cape Town, Bulungula. We sort of compared all our findings that we got from the different interviews. And what we realized is that in terms of accessing the clinic, people in Bulungula at that time had to walk very far to the nearest facility, up to 2 days. whereas people in Gugulethu had easier access to clinics, but also to shops and social services. In terms of the type of support, we found that Bulungula patients had a very strong community support and a very strong feeling of Ubuntu and Imbeko, which I go into a little bit later. Whereas people in Gugulethu had smaller support networks. Then in terms of income, patients in Bulungula had access to subsistence farming or a grant income, but less of formal employment, whereas our patients in Gugulethu had either formal employment, informal employment, or were relying on a grant. And then in terms of health information about their conditions, patients in Bulungula had very little information about their chronic illnesses, except of HIV. And in Gugulethu, patients had a lot more access to information about chronic illnesses, either through the clinic services or through using various media. So this was just to give an overview of the main findings and how they differ between Bulungula and Gugulethu. So one of the patients said, here in Bulungula, they treat us with so much Imbeko. That is something that's very precious here, the culture of respect. I even observe how they treat the elders. It is so respectful. Whether as in Mtata, they didn't care whether you're young or old, you're just a number. Here they really see us. So this is a compliment for the health services that one of the male patients made. So there are three issues that I wanted to discuss with you today that we found out in our work and have also published on. So the first issue is the issue around precariousness. So precariousness is the shortage of resources, which can include money, food, or different types of support. So people in Bulungula and Gugulethu experience different forms of precariousness or precarity, which includes not having enough money, having problems with housing, being exposed to crime, living in informal and often unsafe structures such as shacks, but also experiencing violence inside and outside of the home. These problems made it difficult for people in Gugulethu and Bulungula to stay healthy and to stay on top of their treatment. And in Bulungula, especially living far from the clinic and other social services was really hard for people, and they had to plan a lot around being able to actually get their medication and go for their checkups. So for instance, one of the patients said to us that I always try to ensure that I collect wood to sell so I can actually go to the clinic. If I cannot find anyone to sell to, I borrow money, even if I don't know how or when I'm going to go and return it. I need 100 rand to go and to come back, and even if I don't eat, it's fine. So here you can, one of the patients saying, talking through all the different steps that actually makes her to get to the clinic. So she has to plan so much around it. She has to first go collect the wood, then she has to go and sell it to people. If she can't sell it to people, she needs to go and borrow money somewhere. And then when she's borrowed money somewhere, she can go to the clinic, but then she doesn't know when she can actually return the money. And when she's in transit or at the clinic, she also doesn't have the security of getting a meal at the end of the day. So the second issue that we realized was present in both Bulungula and Gugulethu was the support structures and the feeling of Ubuntu. So in terms of support structures and trying to stay healthy, people use their families, their neighbors, and community members as supporters. But the support was definitely structured differently between Gugulethu and Bulungula. In Gugulethu, the care networks were a little bit smaller, but the different carers provided more emotional support, which was something that was not managed well, or that was not really mentioned by people in Bulungula. In Bulungula, people expressed several times the strong sense of Ubuntu, that people could always ask their neighbors or people in their community for money, food, or assistance with transport. So they felt that even if they might not have anything themselves to contribute at the moment, they could always rely on others. That leads to sort of resilience, but also it leads to self-confidence, because people who do have enough support feel like they can better take care of themselves as well as their families, and they can better manage their conditions, which makes them more resilient because they can rely on others even in times of need. There are two quotes I wanted to highlight here. First, they say, this is about the support from the health services. They treat me very well. They help me with explaining the importance of taking my pills and reminding me when my next appointment is for the blood work for HIV. They're very pleasant. They work with you as a patient and not against you. They're very supportive. And another female said, I feel supported by the staff. It's like they understand the difficulties that people in the rural areas face, having to wake up at the crack of dawn to get to the clinic. After waiting a long time just to be attended to, they treat you with lots of kindness and care. They really make you feel okay about being HIV positive. So they were very supportive. They were very happy with the support that they received at the health services, even if it was a struggle to actually get there. So the third issue I wanted to discuss today is the issue of caregiving, the role of caregiving. So carers, we've interviewed both patients living with 2 or more chronic conditions, including HIV and diabetes, but also we try to engage a little bit when available with the carers who took care of them. And when analyzing the data, we realized that carers are giving different types of support as they assist people to get to the clinic, to have enough food, to know more about their conditions, and to give emotional support by listening, for instance. In Gugulethu, this care was often given by family members, neighbors, or friends. But in Bulungula, it was often community members or people living in the household with them who gave the most care. Also, most of the caregivers were female. They were either daughters, daughters-in-law, mothers, wives, or nomakayas, the community health workers. They played a crucial role. Carers were proud of the assistance that they were giving, but sometimes they also felt like they needed to assist. They had an obligation to assist. Some of the carers, both in Gugulethu and Bulungula, felt left behind, as they did not have enough information from the health system to actually give proper care to the patient. So they are not as informed as the patients are. So one of the carers said that, who was taking care of a son, said that my husband and all my girls, they play a huge part in supporting me and supporting him. We work together as a family and try ensuring that the patient remains well. Is that not what family is for? Living with conditions is not the end for anybody, but it's the end if you're not supported or motivated, and you think that that is what all sick people really want. They want to know that they are loved and that they matter. Somebody else, a sister-in-law of a carer of a patient said, if the patient says, I don't have food, I will tell her, you have tomatoes, spinach, green pepper, and salt. Get it from the garden and you cook and you eat. So she was giving advice around how to eat healthily, even if the patient thought there was nothing in the house. So just as a little summary, we felt that participants in Bulungula experienced a high workload because living with 2 or more conditions and being very far away from the clinic is hard because you have to take a lot of steps to actually get there. And there's a precarity of income, so especially if people don't have enough money, it's sort of also a mental burden, a mental struggle to always make sure that you have enough money saved up to go to the clinic. Most participants could rely on their families and neighbors, but some people in Bulungula did not feel emotionally as supported, but this is for both the patients, but also for the carers. And we've seen that especially the Nomakayas, the community health workers, were an essential support structure for the people in Bulungula, and they relied a lot on their knowledge and their kindness and the way that they were helped by them on a regular basis. We also found that in Bulungula, caregiving is often done by women in the community. And we felt that patients in Bulungula with stable support networks felt less lonely and more informed about their conditions. So they were doing generally a lot better. So I have a couple of discussion points. I just wanted to chat to Lyle and Rajan about if we want to do these questions first, or we want to go straight into the Q&A session that we are facilitating. Let me know what works best.
Okay, Myrna, you can carry on.
Okay, I'm going to give the floor to Dinky, who just came online. Professor Levitt?
Yeah, hi. Actually, I've been online all the time. Thank you very much, Myrna, for that very good presentation. I just wanted to make one point for people who may not be aware of the extent of this problem that we have identified. So the proportion of people who have 2 or more chronic conditions varies a lot by age, by how you look for the conditions, but it can go from about 25% in younger people to about 60 and over 60% in people over the age of 50 to 60. So it is a problem that's a global problem. And in our society, it differs from high-income countries because here we have such a large burden of HIV, and then the people who have a variety of chronic conditions that are hypertension and HIV. Depression too is very common, but unfortunately it's not often, we don't often assess people for depression. So I just wanted to give that kind of context for people who may not be, in tune with sort of a detailed health assessment. Thank you.
Great, thank you so much. We really appreciate that extra context. I think it's really, really important. So firstly, I just wanted to just put a couple of questions around the discussion points so we can start off the discussion from there. So for everybody in the room, of course, we wanted to reflect on the Okay, thank you. So first we wanted to reflect on the findings. So we would love to hear from all of you if it's anything that you feel is missing about these experiences, if there's anything else you would like to add, but also what does integrated care look like for people living with HIV and NCDs in Bulungula Eastern Cape, so we can learn more from everybody in the room. And also to get a little bit more of an idea of what the pathway for care is for people with multimorbidity, and especially how it has changed, because we've had several discussions already with people from the Bulungula incubator, and a lot has changed since 2021, not just because of COVID, but also because of a huge investment being done in with the organization. So yeah, I just wanted to open the floor with these 3 questions, that we can take it from there.
If everyone have a question, thanks Mina for the presentation. It was so good. If anyone have a question, can just put up a hand. We will put him on the chat box, and then Mina will be answering the questions. We'll allocate this for 10 minutes.
Okay, yeah, I just thought I'd jump in with the one of the first questions, and just to let everybody know, there might be some babies crying in the background, but it's also immunization day here at our health point. So, so yeah, just so you know, if there's some noise in the background, the little kitty's getting immunized. I just wanted to ask, Myrna, when you talk about, and Dinky, thank you for giving that overview about multimorbidities and the experiences of people. You know, something that we found, I guess it's not just about disease burdens, but in general, with life in general. You know, when you find that people are struggling with many challenges, and then there'll be one thing that almost puts the household over so that they can't cope, you know. And what we find in households where if you do find any kind of stunting or malnutrition around children, it's households, if they're just receiving the child grant and they're managing to get through the day, they do manage to provide food with those social grants. But if there's one other thing like depression in the household, or alcoholism, or there's a mental disability, or let's say we've had cases where, you know, there's a parent who has a disability and they have to use the child grant to go to their hospital appointments in Umtata, then you find that you can find incidents of stunting coming up and malnutrition, because the household can't, you know, poorer households, they can't handle when they've got this one extra challenge, you know, and it almost takes you over the edge, and then the household can't cope. So I don't know if you have any reflections on that, and how, you know, this kind of work, where community health workers, I know there are people here from NGOs that have programs with community health work, and we see that it's an essential component to what's needed in our healthcare system, because you know, there's only so much that hospitals and clinics can do. But if you aren't, you know, catching households that have these multi-disease burdens, multiple challenges, then it all filters down into the most serious cases with regard to what happens with children feeling the highest burden of those impacts on their households. So if you've got any reflections on that, and how you think the Department of Health might want to look at this kind of work and research and what we can do with it. And then any questions you have in the chat box, you could just add to your response, I guess.
Great. Yeah. Thank you so much. I think it's a really valid point, and it's definitely something that we've experienced both in Bulungula and Gugulethu as well, is that, so if you talk about like almost the scale of treatment burden, it's often like it's often depicted also as a scale, like it's like this, and if everything is in balance and the burden and the capacity are like this, it works. But as soon as something happens, it tips that way, and the burden might be higher than the capacity to actually take care of yourself or your family in this manner. And I think what was really important in both Bulungula and Gugulethu, but especially in Bulungula, is that if something, there's no buffer. So if something changes or somebody has a health emergency, that can put not just the patient, but a whole family on the end of the tipping scale, and actually tip it to the point that people can't cope anymore. If a health emergency, you know, the way that it's often structured in Bulungula, somebody has to rent a car for 500 Rand to go to an emergency room, it's like, it can be the difference between providing for a couple of weeks of food for a whole family. And we've definitely seen examples of that. And you know, the same is that if the person who is living with 2 or more conditions is also the breadwinner and therefore loses their job based on their health, might not just impact just the patient's livelihood, but the livelihood of the whole family, including, you know, grandmothers, mothers, and children. So and that is, we haven't in Bulungula didn't really get any experience with alcoholism or that being like a problem in the household, but it's the same for that. If some of the conditions come with like a mental health burden as well, then that becomes a real big problem. And in terms of thinking about solutions for it, is to see, I think, a patient not as their individual conditions or the sum of the individual conditions, but actually look at the whole household structure and what is needed in terms of caregiving and in terms of in terms of a solution, so people can better cope and look beyond the individual patient, because the patient is not, most cases, is not acting or living in a vacuum. He is influenced and informed by a lot of people around them, but also dependent on the people around them. So I think that's really important to think about, even when treating patients in a clinical setting, but also a very hard thing to do. Dinky, I'm going to hand over to you.
I apologize, I was muted. Thanks, Rajan. You've raised a really important issue, and that is the kind of intersection between poverty and health. And you know, the question is this an expression of poverty? Is it poverty plus the sort of the multi-generational nature of so many families that we're dealing with, or is it an intersection between the two? And then, you know, when one thinks of solutions, I think it's incredibly difficult to think of solutions, because in a sense, the precarity that you means of change, whether they are disability or kind of old age. And I'm sort of struggling in my mind to think of another intervention. The only thing I can think of is, you know, like sort of gardens, which you have in Bulungula, where people can grow things. But anyway, those are just my thoughts.
Great, thank you so much for those insights. I saw that there's one question in the chat, and I actually wanted to invite Donald to actually pose the question to give a little bit more insights of what the question is about, because he said, I wonder what is the role of community-based organizations, as most of them are into caregiving. Can you just give a little bit more of a clarification about what you mean by that, so we can start a discussion from there?
Yes, thank you so much. So you mentioned that most of the caregiving is done by relatives as well as the community health workers. And I was wondering if also there are community-based organizations that are into caregiving and playing that role, especially in the rural areas. And also maybe just a follow-up question would be like, especially in a rural area where services are quite far, are there any initiatives to make sure that patients gets maybe like a 6-month supply of medication, so that it reduces them having to travel regularly to the clinic? Thank you.
Great, thank you so much for clarifying that. So this is really hard, because I'm not an expert, and especially not in the Eastern Cape, in terms of the NGOs being available there. I know that the Bulungula incubator relies heavily on and works very well with the Nomakayas, who have been a big essential part of their of the lives of people living with 2 or more chronic conditions, that were really really had a fantastic role in people's daily lives. I'm not sure, but I'm sure that there are other organizations in other parts of the Eastern Cape who are doing similar work, and I'm sure that people from the Bulungula incubator can actually answer that question better. Similarly, getting more than 1 month supply of medication is absolutely a solution, but I don't know what the current rules and policies are around that, and it also depends on the type of condition that you have, whether or not you can get a supply for more than a month. So I can't answer your question, but I'm very happy to open the floor for people to give more insights into that. Rajan?
Hi. Actually, this is Siggy from Bulungula Incubator. But thanks, Donald, for your question. And just one thing that we have added. Sorry, there might be some kickback. Maybe turn it on. Okay. Okay. Can you guys hear me okay now? So another solution that we've implemented here since Myrna and her team were in Bulungula is that we started an external pickup point. So we actually have written up an entire op-ed of steps of how we've been able to register for that. But now, instead of people who have HIV and other chronic conditions needing to go to the clinic each month to collect their medication, now they're able to pick it up from our health point, or our community health workers can deliver the medication to their houses. And so there's different rules for the different chronic illnesses. So I think right now there's also legislation happening of trying to make it for a longer period of time of 6 months rather than every 3 months. But I'm really happy to share that information with you, Donald, and anybody else who's interested, because that's been a huge success for us in terms of getting treatment to people and further reducing the gap to access to healthcare.
Great.
Can I just
Go ahead.
ask, that sounds, and it sounds like the most incredible initiative, and congratulations on that. Is that the ARVs plus all the drugs people need for non-communicable diseases? And so that's question one. And question two is, do people get assessed with their, for the level 6? Thank you.
Thanks, Dinky. Sorry, I didn't hear the second question very clearly. I don't know if maybe you could put it in the chat. But the first question is yes. So it's chronic medication. So the external pickup point, there are different rules. So you have to be you have to have like a certain viral load, and you have to be registered onto the system. But once you're registered onto the system, anybody living with a chronic condition like HIV, diabetes, hypertension, can be enrolled within the program, and then they can come and collect their treatment or their medication from the health point or from the community health workers.
Thanks, Siggy. Thanks for those questions. I think we could actually do a webinar just on pickup points and on medication. So we'll put that on the list. I think it could be a really fascinating discussion. And there are also, just to add to some of the other points, there are several organizations that in the Eastern Cape that do community healthcare work, and I think we could have further discussions on these topics. I think it's really an excellent addition, and I think in the new health system, the new NHI, having a community health worker component in addition to the larger hospitals and clinics, I think is essential to have comprehensive healthcare in the country. I think we're bumping up against time. We wanted to keep these webinars short and sweet so that people could make it in time, and also to to have ongoing discussions and rather more frequent discussions rather than longer ones. So we'll take all these points and these questions into the new year, into our webinar series. And I'm sure we could have Myrna and Dinky from the Chronic Disease Initiative for Africa from UCT join those other health webinars, so that we have more focused discussions on further topics. If anybody has not put their name and organization in the chat box, if you could just do that now, so that we could keep a record of who participated, and if you could put your email address in as well, then we can keep you on the on the mailing list, so that the future health webinars and other topics as well can be sent to you. That would be great. So I think I think let's just gonna thank everybody, and we'll have additional ones in the new year for further discussion.
Rajan, may I ask something? If anybody from the sort of the health and the community point of view has any additional thoughts based in response to Myrna's presentation, and you know, potential interventions, we would be very grateful if they could circulate them.
Okay, we can play that role, Myrna. We've got, I put my email address in the chat box right at the top, so you can email me, or you could also go to bulungula.org to get our contact details. But my email address, rajan@bulungulaincubator.org. I also see Myrna's put her email address in the chat box as well. Feel free to email us and keep the conversation going. And it does feel like, yeah, we should have a follow-up. Perhaps we could have a follow-up discussion and invite everybody that's been on this call. Yeah, I was just trying to get that balance between having something that's not too onerous in the diaries, but if we have people that want to have additional discussions, we can certainly make the discussion longer at the next one. So yeah, please keep putting in the email addresses and the names so we can stay connected and have the follow-up discussion. Is that fine, Myrna? You happy with that?
Yes, absolutely. And I am also happy to share this presentation with anybody if they just send me an email, and then we can continue the conversation from there. Absolutely.
Okay, brilliant. So all the email addresses that are in the chat box, we'll send the presentation to everybody. And Myrna, I think, can also will be able to share the in-depth studies that she did, where all this information comes from, and we could facilitate an ongoing discussion with everybody that's interested. So yeah, so we'll do sort of a group email with this presentation, the studies, and then yeah, and then additional questions. We could do a webinar number 2. It seems like there's interest in that.
Great, thank you so much.
Great, thanks, Myrna. Okay, Lihle, over to you to end off.
Yeah, I would like to extend a big thanks to you for your presentation, for your engagement and thoughtful questions. I would like to remind you that if you want to rewatch the webinar, you can go to our YouTube channel, and we are also able to share. Thank you.
Thank you, everybody, and have a great Christmas and New Year. And we will do part 2 in the new year.
Thank you. Bye.
Thank you.
Thank you. Cheers.
Bye.
Thank you very much. Goodbye, everybody.
Bye.